Water. Hi, everybody. I think we ought to get started so we have plenty of time. We still have some. Come on in, John. All right, thank you very much. This is a very special occasion for several reasons. First of all, it's Ole Teenhouse's first Grand Rounds as chair, and we're delighted to have you here. And secondly, we're very fortunate to have Tor Wager as our speaker. I've been asked to tell you that he has nothing to disclose. That's with regard to financial conflicts of interest, but he has a great deal to disclose with regard to pain and emotion. Because despite his tender years, Tor is one of the world's leading authorities on the neural basis of placebo effects, and relatedly is also a world-class researcher on the neural bases of emotion and emotion regulation. Tor was initially invited to Tucson by the Cognitive Science program, where he'll be speaking on Friday about similarities and differences in the brain between physical pain and the social pain of rejection. He'll be spending most of tomorrow hosted by the highly successful pain research program here in our Department of Pharmacology. And I think it's notable that Frank Parecka, who happens to be here in the audience, who's head of the pain research program, strongly encouraged everyone in his lab to attend all three of Tor's talks because he is a brilliant scientist who can help us better understand the mechanisms of interaction between pain and emotion. In 2010, Tor became the director of the Cognitive and Affective Control Laboratory and associate professor in the Department of Psychology and Neuroscience at the University of Colorado in Boulder. He moved there after 5 years at Columbia University in New York, where he was an assistant professor. I think it's remarkable that it's only been 9 years since 2003 when Tor got his PhD in psychology at the University of Michigan. And that particular year, he was lead author on a seminal paper in Science on brain mechanisms of placebo using fMRI. He's currently has 3 NIH grants, is widely sought after as a speaker and consultant. I think it's a testament to his special abilities that he continues to run labs in both Boulder and at Columbia in New York. Tor has been a leader in creating new neuroimaging methods that have made some of his remarkable discoveries possible. And relatedly, for the past 4 to 5 years, he's run the day-long advanced fMRI program, fMRI workshop at the annual Human Brain Mapping meeting, which is going to be held in Beijing this coming year. Just to give you 2 examples of Tor's innovations. He created a program to combine results from multiple neuroimaging studies from meta-analyses that pinpoint exactly where in the brain significant effects occur. This has been used, for example, to demonstrate that different basic emotions like happiness, sadness, and disgust do not have a unique neural circuitry of their own, as has been commonly thought. He, secondly, adapted the statistical principles of mediation analysis to the brain imaging environment so that he and now others can show how the brain mediates the relationship between psychological states, such as stress on the one hand, and changes in peripheral physiology, such as heart rates that are due to stress. In recognition of this work, as well as his many other contributions, the American Psychosomatic Society made Tor the first recipient of a new award for outstanding neuroscience research in psychosomatic medicine in 2010, and just selected him to join the governing board, which leads the organization. To top it off, Tor is also a very special human being. He's the primary caretaker of 2 adorable children, and is, at his young age, I think, a rather wise person. As he said to me recently, I believe in giving people the benefit of the doubt way beyond what is reasonable. So it therefore gives me great pleasure to ask Tor to come to the podium to speak to you about the neural bases of placebo effects in pain. Tor.
Well, thank you for that very generous and somewhat embarrassing introduction. It's, you don't know. You never know when somebody's going to say something that you say to them in a talk. So, but that's nice. I'm really delighted to be here to speak to you today and to meet all of you. And I hope to be able to say hello and meet as many of you as possible today and or tomorrow, should you choose to return in the future for other talks. So today I'm going to talk to you about placebo effects in pain and sort of the story that's developed. We all suffer, and avoiding suffering is one of the fundamental pursuits of human life. This is true to such an extent that many of the philosophical institutions and traditions and spiritual traditions that we have are centered around avoiding suffering so that we can become free to choose our own paths and to enjoy our lives. And this is perhaps what prompted the Stoic Marcus Aurelius to write, "If you're distressed by anything external, the pain is not due to the thing itself, but to your estimate of it. And this you have the power to revoke at any moment." And that's certainly an optimistic sentiment, and that's also one that's been shared by practitioners throughout history. This batswing reminds me that there are over 4,000 ancient remedies that were documented by the historian and scientist Arthur Shapiro. Many of them are from bats' wings to eyes of newts and other things. Almost all of the effects of these treatments are now attributable to placebo, to the belief itself in the treatment. Some of them were even deadly. One of my favorites is a treatment in the 1800s in the U.S. for yellow fever that involved bleeding out of the human body more blood than is actually in the human body. And in spite of this dangerous cure, this physician remained prominent and successful for many years. This is Hippocrates. This is true from ancient times in both Eastern and Western medicine to modern ones. Hippocrates wrote this: "The patient, though conscious that his condition is perilous, may recover his health simply through his contentment with the goodness of the physician." And on the other side of the world, this is from the Yellow Emperor's Inner Classic, original acupuncture text. "If a patient does not consent to therapy with positive engagement, the physician should not proceed, as the therapy will not succeed." This goes through the 1900s in the U.S. This is Richard Cabot from Harvard saying that everybody essentially treats people with placebo pills, with sham treatments from time to time. And today, 45% is, number one, the number of Americans who use prayer for health reasons. And number two, the number of physicians who, in a recent study, reported using placebo treatments in their clinical practice. And by the way, 96% of those physicians believed that placebos could be effective. And this, almost $34 billion, is the out-of-pocket expenditures for alternative healthcare in 2007, despite very little actual scientific evidence that many of these treatments are effective. And $28 billion is the total NIH budget that year, same year. So people are spending more money on really treatments that they believe in than we actually are spending doing research on them. The point of this talk really is to ask this question: can beliefs be helpful in relieving pain in a meaningful way? And by meaningful, I'll tell you what I mean, but we're going to try to look for some objective neurophysiological evidence that they're helping. But let's start with a couple of clinical examples. Placebo treatments or sham treatments can be effective in a variety of clinical situations. This is an example here from a review article by Coloca and Benedetti showing some of their data. And this is two drugs, one opiate-based, one not. And if you look at this dark purple line, what you see is the time course of improvement. This is the injection period here. This is several hours afterwards. Pain goes down, and then it comes back up later. So this all looks good. Now, if you look at the light blue line, this is the response to that treatment when the patient doesn't know that it's getting it, that they're receiving it. So it's given in a hidden manner. And there you see much reduced benefit. So whether a patient knows they're getting a treatment can actually make a substantial benefit, have a substantial effect on the overall treatment response. Another kind of example comes from really several large-scale trials of acupuncture that have been done recently. And in this one, there were over 1,000 people across many centers throughout Germany. And what you see here on the y-axis here is the percentage of patients that showed pain relief over a sort of a prolonged period of treatment. I think it was 6 weeks. And this is the standard care, so you get about a 35% improvement. And it turns out that, and this involves both physical therapy and drugs, that acupuncture was substantially more beneficial. So highly significant, clinically meaningful improvement over the standard of care. But they also had a sham acupuncture group, which involved the same kind of procedure, but they didn't get the actual acupuncture, real acupuncture stimulation at those sites. And what happened is, it's also substantially better than the standard of care and not statistically different from the Virum, the real acupuncture treatment. So what's happening? Either the standard care is bad, which is actually a less likely alternative, or the sham acupuncture itself can be effective, is effective in this case at relieving pain. So on the one hand, this is culminated, in this kind of headline from the New York Times a few years ago. Placebos proved so powerful, even experts are surprised. And we were working on our initial studies at the time this came out, and I thought, oh, they have it all sewn up. Okay, I better not do research. But it turns out, a couple of years later, the New York Times published this headline: placebo is more myth than science. And this was done after a pair of Danish scientists, Robochen and Goethe, published an influential paper in the New England Journal of Medicine in 2001. And what they found was across many different conditions, many different medical conditions, there were significant placebo effects in continuous outcomes, but not outcomes that are binary in nature, like did you quit smoking or did you not? Did you live or did you die? But these sort of continuous, more subjective outcomes they found evidence for. Some of the largest effects were found in pain. And nevertheless, they concluded that there were no real placebo effects, and that the effects that did exist in these clinical trials in pain were really because of a sampling bias or statistical artifacts, or patients simply reporting what the physicians wanted them to hear, the so-called demand characteristic. So which one of these two stories you believe probably depends on how you think about pain and what it is in the brain. And this is really what I'd call an old model, feed-forward model of pain. This might be even pre-1960. But there's this idea that there's organic pain, which is what's coming up the spinal cord, nociceptive afferents, and that, through some centers here, leads to this pain sensation, and then produces reports. And if this is true, and there's this difference between organic pain and other kinds of influences, psychological pain and distress and just being afraid and other kinds of things like that, then these other kinds might just actually influence the output process, the reporting process, i.e. your judgments and decisions about the pain and not the actual stuff coming up. Right? And if this is the case, then all effects of placebo and all other cognitive interventions and cognitive therapies are post-nociception. They're about your decision-making process. But we've known for a long time that that's actually not the case in the brain. It looks something more like this. There's a recurrent process. In your pain group people, Frank Perka and others in the group, do very detailed studies of something. I've just drawn a big arrow over here. But there's this ascending feed-forward process that ultimately ends up in verbal behavior reports. But there's also these descending feedback at multiple levels of the neuroaxis, starting from the most ventral parts of the medulla on down, and that in this case, it's possible that thoughts and feelings can not only influence what you say and what you decide, but also influence nociception and the creation of the pain experience at a deeper level. So this distinction between these two ideas really drives the need for brain-based measures. Are placebo effects really about decision-making biases and cultural norms and other things which we know can influence the relationship between what you essentially experience and what you end up saying, what you communicate, unfortunately? Or is it measuring something else? And the brain can help us do that. And in my lab, we take what you might describe as an integrative neuroscience approach, looking at evidence from multiple different kinds of methodologies. Now we've used the two that are here, which I'll mainly focus on today, as well as some other ones to try to address this question. Over here on the right, you might all be familiar with this, but just in case you need a refresher, this is the fMRI scanner. Most of the studies I'll talk about use this scanner, and the beauty of what it can do is it can assess activity across a living human brain in about 2 seconds, give or take, and it can make about 200,000 different measurements of activity in the brain. And so you really get this rich data on the brain dynamics unfolding over time. The other methodology here, PET, is neurochemistry, is really good for assessing endogenous neurochemical effects. And those include, for placebo studies, especially opioids and dopamine. And the idea is to inject a radioactively labeled ligand, a tracer, into the bloodstream. It binds in the brain, and where there's endogenous activity of, let's say, opioids, it competes with the labeled radio tracer at those binding sites, resulting in a drop of binding, in which case one can infer that there's actually a release of endogenous opioids or dopamine. And the contributions of neuroscience to this problem at a broad level are twofold. First, it can give us an idea about the mechanism. Which brain systems are involved in placebo analgesia, in creating it. That can give us ideas about where and how we should intervene. It also can give us ideas about the plausibility of what those systems are relative to what we know neurophysiologically is involved in regulating nociception and the creation of pain experiences. A second thing that it can give us is what I'll call intermediate markers. Or you might call them endogenous phenotypes and endophenotypes as well. And this is really a brain pattern or activity in a brain region that can tell us something about how early and which brain processes are actually affected. So an intermediate marker for pain would be one that tracks pain experience. And so in the talk today, I'll use brain measures that we know are influenced by changes in pain experience and that track changes in pain experience. And those will serve as surrogate markers. And we're actually working very hard now to try to improve those markers so that we have brain patterns that can sensitively and specifically track pain experience and therefore serve as, biological objective correlates. Which can then be tested for placebo effects. And this is the idea of multiple feedback loops through these brainstem systems here, and then back down to the spinal cord. This is the PAG in the midbrain. I'll focus on this. And the idea here is that there are multiple layers of control. So we first saw these, I'll play it one more time. We first saw these brainstem systems. There's these ascending nociceptive systems, and then there's descending systems. And this is through the hypothalamus out to the body. There's this intermediate layer of control by the subcortex, the amygdala, the nucleus accumbens. And then finally, there's this cortical layer of control, which is really centered on the VMPFC, the ventromedial prefrontal cortex here, the hippocampus, and the posterior cingulate. And this sort of triangle, I'll get back to again at the end of the talk. But for now, I'll just point out that this is the only area of the cortex, to my knowledge, that sends projections all the way back down to the lowest levels of the brainstem nuclei that regulate autonomic output to the body and that can regulate nociceptive transmission as well. So this has a privileged anatomical connectivity with these lower brainstem centers as well. And regarding the second point, these preliminary intermediate markers, This is a pattern of activity, and these maps that I'll show you, these are slices. This is a sagittal slice to the side of the head. These are axial slices from bottom to top going through the head. And the bright colored spots are areas, in this case, that track reliably an increase in painful stimulus intensity. So high pain versus low pain in each of these areas. And this pattern is one that is really very reliable, and among all the phenomena that I know of in the cognitive and affective neurosciences, it's actually one of the most stable and reliable ones. And so you can see here the anterior cingulate cortex, the thalamus. This is the PAG in the midbrain that I pointed out. There's the cerebellum. There's the insula, the anterior insula, and the dorsal posterior insula and S2, and some other regions as well. So what we're going to do is look for placebo effects on activity essentially in this pattern. And because I take my task here today to give you a sort of summary of all the stuff that's happening in this area that's interesting, I'll summarize it in this way. There really are 4 different kinds of evidence now that have been brought to bear on this question of placebo analgesia. And the first and oldest one has to do with pharmacology. In particular, experimental administration of the opioid antagonist naloxone, which was done first, actually, in the late 70s by John Levine and Howard Fields. And what they found was that giving naloxone could reverse a placebo effect, in some cases, in their case, without actually changing pain itself. So it selectively blocked a placebo effect. And that, to me, sort of put placebo back on the map as a potentially real, pharmacologically and neurophysiologically real phenomenon to be explained. It suggests that it's not just domain characteristics or reporting biases. I'll also talk in some more detail about brain activity studies with fMRI and PET, including a number of these that you'll see here. A third source of evidence is, I won't talk about too much, but it exists, is on event-related potentials in electroencephalography. And these studies collectively show reduced markers of early nociceptive processing with placebo treatment. So there's a characteristic potential, the N1P2 complex, and usually in these cases, people use a laser and they give little pinpricks of pain. And when you get a pinprick of pain and you have a placebo treatment that you think is going to be helpful, then it'll help. And that potential will be reduced. And then the fourth is the neurochemistry or PET studies, and particularly opioid and dopamine studies. So those are the 4 kinds of evidence. So now I'll take you through some of the results that my lab and other labs have found over the past 8 years or so, and what they mean in terms of the study of placebo analgesia overall. Before I do it, I just want to walk you through what the actual study looks like, at least a thumbnail sketch at a basic level. So here I'll talk about 2 studies, a pair of studies that were published together. Study 1 is electric shock on the right arm, the 24 people, and study 2 is a thermal pain study on the left arm. So 2 different modalities, 2 different arms, and what we did in this case was look for effects that replicated across both studies, placebo effects that replicated across both studies. And the idea is this: once a participant is in the scanner, we give them a cue that says, "Get ready," and there's an anticipation period, and then there's this heat that comes on or shock. In this case, they're experiencing the heat, then they rest, and then they rate the pain, and then they rest some more. And the idea is that we can separately assess the fMRI activity related to the anticipation of pain when you're preparing for pain itself, and compare that with and without a placebo treatment. We can assess pain-related activity during the experience itself, and then separate those things from the activity that happens when you're actually judging the pain itself. And that's the idea. All right. And the setup of the experiment goes something like this. In this case, first we do this sort of calibration on the skin, and the idea is to give people different temperatures and choose temperatures that correspond to low, medium, and high subjective pain levels for them. Call those 2, 5, and 8, 8 as near as hot as they can stand. And then we would apply placebo and control creams. So the creams are actually identical creams. The only difference is in the instructions that we give to participants. So when we apply the placebo cream on this arm, on this patch of skin here on the arm, we might say, this is a powerful painkiller. It's going to block pain. This is lidocaine. It's been demonstrated to work, and we're going to understand how it works in your brain. When we apply the control cream, we apply the same cream from a different jar, and we say, this is just to have something in your skin. It's not going to help you or change your pain experience in any way. After that, we give this manipulation period. And in this manipulation, we would stimulate the skin at these two sites, the green on the placebo site and the red on the control site, so each person serves as their own control. The purpose of this phase is to increase the expectation that the cream is actually going to benefit them. So we told them that it's going to work, and we say we're going to stimulate your skin at level 8 in both sites, so it's going to be hot, hot. And what actually happens is, here on the control site they get the level 8, but on the placebo-treated site we reduce the temperature to level 2. And we think really there are two different things that are happening, and I won't get into the details of this now, but we think that we're enhancing the expectations. And we also think that we might be facilitating a learning process that occurs partly independent of people's expectations. So we now think that placebo effects are only partly under your conscious control. And this does both of those things. Finally, this is the test phase, and this is the critical phase where we're going to look at the outcome. And here we stimulate two different patches of the skin so that there's no actual sensitization of the skin. And here we're giving the same exact temperature, a level 5, on both regions. And we counterbalance the sites, and we counterbalance the order of the testing on the two sites so that there's no experimental confounds. And the idea is the difference in pain reports between these two conditions is the placebo effect, placebo analgesic effect. That's the difference in pain ratings. And we're going to look for a similar difference between in the brain, between responses when you're getting the stimulation under these two conditions. And those are the placebo effects in the brain. If that's unclear in any way, stop me and ask me now so that we don't lose you. And if you don't, I'll assume that it is and go on. Okay. And this is what happens behaviorally. We put this cream on and test both of these sites. And when people get stimulation on the placebo-treated site, there's a reduction in pain. It's about a 22% reduction in this study. This is about 50 people. And about 76% of this sample showed the effect in their right direction. We're placebo responders, if you will. So there's a substantial drop in pain. And this has been found in many other studies. I've listed some of them here, but there really are dozens of studies like this that have shown similar things. So you report less pain. The critical results, I think, are the brain results. And I'll just give you a sort of a high-level summary again. And what we see is reduced responses to painful stimulation with the placebo in several of those areas that are pain responsive or pain processing regions that I showed you earlier. And those include the rostral cingulate cortex, which has also been associated with other kinds of affective pain modulations in particular, like effects of hypnosis. And others, the insula, here it's mid, also anterior insula, and the thalamus, this is really extending here into the parahippocampal cortex and thalamus. So those three areas, the rostral cingulate, the anterior insula, and really the medial thalamus, are the three that I'm going to focus on because those show the most reliable downregulation when you get a placebo treatment. So in many of these areas, the decrease in brain activity was correlated with the decrease in pain reports as well. So you can see that here for the rostral cingulate for both studies. The larger the behavioral placebo effect, the drop in pain, then the larger the drop in brain activity as well. This study also gave us some clues as to what the potential mechanisms of placebo analgesia might be. And here, what you're seeing is a plot that shows we found increases during anticipation of pain in this area around the PAG, periaqueductal gray, and the dorsal raphe nucleus, which are both important in descending modulation of pain. And those showed up, and they also were correlated with increases in the prefrontal cortex. So we also found increases in the lateral prefrontal cortex in both studies, on both sides. And the larger the prefrontal response to the pain during placebo, the larger the increase in the midbrain. So that you can see in that scatter plot there. And that's important because the lateral prefrontal cortex and medial prefrontal cortex both send projections directly to the PAG, which sends projections directly down to, through the rostroventral medulla and some other nuclei down to the spinal cord, and actually is capable then of affecting nociception at a spinal level early on. It's also important because opioids themselves and the PAG are major targets for analgesia in humans and animals. And this has been done in many, many studies over the decades. And because of the second point that I mentioned before, that if you block opioids with naloxone, you can reverse those behavioral placebo effects. So this made us think that the opioid system was likely to be involved in this. And then what we're seeing is the PAG and part of the descending modulation system. So the next logical step really was to do a study using PET to look at opioid system activity directly. And what you're seeing here now is a map of areas with the same kind of setup, right? Every person gets both placebo and control. The temperatures are identical, so the stimulus intensity is identical. And the differences you see here reflect endogenous opioid release when people get a placebo treatment relative to a control treatment. And what you see here, I'll point out some of the areas. Green areas are the areas that we looked at, that we identified regions that were of interest before we started the study. And this is the PAG. So we see opioid release here in the PAG in the midbrain. That's important because this is a major producer of opioids and sends projections up to the forebrain and other parts of the cortex. As well as the ventromedial prefrontal cortex here, the anterior cingulate, where I showed you the correlation before, the lateral orbitofrontal cortex, which, as I'll get to soon, is probably quite important for emotional appraisal and for essentially creating placebo analgesic effect. Okay, so we see direct evidence for endogenous opioid release. Since then, other labs have also produced a number of other results. There are now maybe 30-something published studies of placebo analgesia using brain imaging methods. And those were some of the first ones. Since then, this is another group in Germany, Ulrike Bingel, and they found this ventromedial prefrontal cortex under placebo treatment showed increased connectivity with both the PAG, which might be expected, and also with the amygdala. And this was another study by a German group, Falk, Eipert, and Christian Buchel, and what they're claiming in this study is that when you get painful stimulation with the placebo versus the control, there's increases in activity here in the PAG, the hypothalamus, and what they're here calling the rostroventral medulla. But I leave it to the pain group to decide if this is really the RVM or not. I'm not sure, but we are definitely moving towards trying to be able to image this at a high resolution and really try to dig into that lower brainstem system. So all that supports the idea of descending modulation of nociception. And this was another paper which was really striking. What they did is they actually imaged the C-spine here in the spinal cord using fMRI, and this is the cord here across, and this little spot here is a spot which showed reduced responses to, again, painful heat with the placebo treatment. So here's without the placebo, here's with the placebo. So they published that a couple of years ago. So that suggests that placebo effects can reach really all the way down to the spinal cord under certain circumstances. And we're working hard now to figure out when that's the case. Another study that we did recently can help give us an idea about the circuit dynamics, or how this process might unfold across time. And this paradigm also produces particularly powerful effects of expectation. In this case, what we're manipulating is not the belief about the treatment itself, a cream, but the belief about the upcoming pain. And so here, again, in my abbreviated version for this talk of the paradigm, we essentially gave people two kinds of auditory cues that were counterbalanced. One signaled high pain, one signaled low pain. And we gave them some experience that was the case, that the high pain cue leads to the high pain stimulus, heat, and the low pain cue leads to the low pain stimulus. And what we then started to do is intermix stimuli that were at an intermediate temperature that were the same temperature for both the high and low cues. So now, again, we're holding the stimulus itself constant, and we're asking, what are the effects of the cues themselves on how you experience and how your brain processes that painful heat? And so we're interested in what the effects of cues are on your pain experience, right, at a constant level of stimulus intensity. And here's what we find. When you get a low cue and low heat, this is what you get. When you get a high cue and high heat, then the pain is much greater. That's as expected. Now the critical conditions in the middle. What happens when you get the same intermediate level of heat with a low versus high cue? And there's the difference. And this was actually true for, I think, 29 out of 30 people in our sample. So it's really reliable. It was a very strong effect. It works. So the pain is really quite different. All right. And now I'll show you what happens in the brain. What happens when people are experiencing that heat when they get the high cue compared to the low cue. And what you see is, I'll just focus on these areas in yellow because these are all the areas that show increases. You see increases in the lateral prefrontal cortex, the insula and the cerebellum, also this ventral striatum and amygdala, and this I'll refer to later as sort of value learning circuitry, as well as some of the areas that are most closely associated with pain experience. The insula is one of them, and S2, the somatosensory cortex extending into the posterior insula, is another one. And we also see increases in, an area that's consistent. I'll call this pons or maybe rostral ventral medulla that's consistent with that in the other Falk-Eipert study. So it looks like when you expect more intense pain, there's really this whole set of circuitry that's responding, including some of these early pain responsive and pain modulation areas. And then we use what Richard mentioned in the introduction to mediation analysis to try to understand more about how the brain activity relates to pain reports at a more fine-grained level and how those cues influence that activity. So what we did is we looked for areas that formally statistically mediated the cue effect on the pain. So what does that mean? That means the area has to respond to the high expectancy cue, and it also has to predict how much pain people reported for a given cue level on a trial-by-trial basis. Right? So these are areas that essentially connect up the cue effects on the brain with the brain effects on the pain report. And sort of connect the dots. And what we expect is a much more circumscribed set of regions. And we really expect those regions I showed you before, the rostral cingulate, the medial thalamus, and the anterior insula, because those are the most reliably influenced. And that is actually what we saw. And so these are these three areas here, the rostral cingulate, medial thalamus, and the anterior insula. And they have all these properties. So we really think that these areas are most closely tracking the heat, and they're linking the expectations to the actual changes in pain response. And then we could ask, well, what's happening? You're getting these cues. What's happening when you respond to this tone and you start to feel either threatened or safe, essentially, that is linked to those changes in heat? So now what we did is we used these regions as the outcome and said, well, what's happening during the anticipation of pain that's mediating the effects of the cues on these changes in brain activity? And what we expect is one of two different things. We might expect there to be a sort of lateral frontal information processing based modulation of those regions directly, or we also might expect changes in essentially that valuation circuitry, what I've called the ventral striatum and the ventral medial prefrontal cortex. And we didn't know which of those things it was going to be, what these mediators were going to be. And what it looked like is the value, the latter, the value. So this is the area around the nucleus accumbens here, and this is the area in the ventral medial prefrontal cortex. So greater activity here during the anticipation of pain essentially sets the stage for greater activity here, which leads to greater pain report. Okay. And there are a number of other studies to choose from. I won't have time to go over all of them, but I picked a few studies out that help to underscore the importance of this subcortical valuation circuitry in the process. And the idea is that understanding the circuitry and whether an individual person responds more strongly or less strongly in these regions can help us understand who's going to show a placebo response and who's not. And I actually won't talk in detail about that now just for time reasons, but I'll show you a couple things from several different labs that illustrate this sort of space of things. Now, this is a study from Jean-Claude Zubietta's lab, and I chose it really mainly because this is the only study to do in the same people opioid and dopamine imaging. So it's very methodologically special. And so what you're seeing here is, I'll just focus on the left-hand side, placebo responders, those who showed analgesia versus those who didn't, non-responders showed less. And what you're seeing here is mu-opioid increases in the area around the nucleus accumbens and ventral striatum, which we had also found in our 2007 paper, and increases in dopamine response in those same areas. All right. And this is important because those areas, dopamine in particular, is actually involved in all kinds of value learning responses, especially on the positive side, but maybe on both sides. So this is another study that also shows an individual difference effect that converges on the same area. This is done by Petra Schweinhart and Kathy Bushnell. And what you're seeing here is a set of relationships between three measures. One is here, the placebo analgesic response. So here on the right, farther to the right is greater placebo analgesia. And here what they're looking at is gray matter density measured with structural MRI in the ventral striatum. So the greater the gray matter density here, apparently, the larger the placebo analgesic response. That gray matter density was also correlated with a sort of a broad-based personality measure that includes optimism, which has also been found in several other studies of placebo analgesia as a predictor of individual differences. Optimism and this behavioral activation, sort of behavioral drive, a high-risk preference, and so on. So these are in some sense, the go-getters. We're showing the higher gray matter density and the larger placebo analgesic response. In another study, we have found this. We looked during the anticipation of pain, and we showed changes in two systems that are important. And again, I'll just focus on the yellow areas mainly. The lateral prefrontal and parietal cortex here, and the lateral orbitofrontal cortex, right, which are involved primarily in the maintenance and manipulation of information and the specific expectations for specific outcomes in animal studies. So maintaining a cognitive representation of an outcome in particular. So we found both of those systems are important. We also saw correlations in the ventral striatum that I'm not showing you there. So if you put these pieces together and you look at what are the most consistent placebo effects across these laboratories to date, this is a meta-analysis or a summary image from the 30 or odd so studies that have been published so far that show consistency across laboratories. So to show up in blue on this map, there have to be at least 3 different studies who report the same kind of finding within 10 millimeters of one another. And these are the areas that show up, and they are the areas that I've been talking about, hopefully unsurprisingly now. The rostral anterior cingulate cortex, the medial thalamus, and the anterior insula, and this also extends into the cauda a little bit. So those areas are really consistent. What about somatosensory regions? What about S2? And actually, I'll reserve talking more about those things for another day when I'm here. So if you're really curious, we can talk more later. But let me suffice it to say that those effects are not so consistent. We found them in the one study that I showed you, but we had very strong behavioral effects as well. And I think actually that the difference between who gets this somatosensory changes and who doesn't really depends on exactly how you do the study. And I think the ones that actually involve more learning, longer and deeper learning processes are going to be the most important ones. Okay, and just to show you that broadly speaking, this representation of the high versus low pain from our lab, and you can see some of the correspondences between those areas. All right, so it's not all of them, but it's many of them, especially the ones that are most closely associated with pain affect, or the emotional experience of pain and the value of pain. And the red areas here are areas that show consistent increases in activity across laboratories. And those include here the PAG, the periaqueductive gray that I told you about, the lateral orbitofrontal cortex, and also the rostral anterior cingulate cortex, interestingly, because it actually responds during anticipation, and it goes down during pain experience. And the lateral frontal cortex here. Okay, so we have consistency across labs. Now we're starting a program of research that asks, are placebo effects then, what are they at a psychological level? And one thing you might think is that they just boil down to effects of distraction. So if you get the placebo treatment, you think, I don't have to pay attention to this as much, and you might distract yourself, pay attention to something else. So that's possible. And there's actually some evidence that suggests that that's the case. So, there are placebo effects in a group of Alzheimer's patients who have lots of pathology, admittedly. Placebo effects correlated with frontal lobe function in a battery of tasks. And another study, transcranial magnetic stimulation, which is a magnetic pulse that's delivered to the lateral prefrontal cortex, actually disrupted placebo effects in that study. So those are interesting findings. So our prediction was, if placebo effects and cognitive control or attentional resources share common resources, they should either enhance one another or interfere with one another. So I'll walk you through the predictions and the task, the basic design. So what we did is we gave our standard placebo test here. So either got a placebo or they didn't in different sessions. And half the time when they got the placebo, they were doing this working memory distractor task, and half the time they weren't in each of those two conditions. So that way we could look for the interactions between them, whether they interfered with one another or not. And the working memory task was one that we had shown previously that really interferes with pain. You have to remember a series of letters, and every time you get a letter, you have to say whether it matched the one 3 letters back. It's just a very well-studied, sort of standard task. And we did it in a way that ensured that it would be really continuously distracting, essentially. So one alternative, it looks like this. If they require common resources, then when you're really highly distracted, the placebo effect should be reduced. And that pattern would look like this. On the other hand, it's possible that when you have that distraction, that really lets the placebo do its job and work better. So in that case, when you have the distracting task, the placebo effect would be larger because it would be facilitated by the availability of something external to you and to the pain itself to pay attention to. And then the third alternative is that they're parallel lines, which would suggest that they require different processing resources. Doing something very cognitively demanding in this case would neither enhance nor disrupt placebo effect. And the results of this study are here. And so what you see is that those effects were additive. So in fact, being highly distracted did not interfere with the expression of the placebo analgesia. So based on that and a few other findings, we now think that it's not really reducible to distraction or attention at all. It's really a change that is centered in the value systems of the brain and in learning and value systems, which is also why I picked on those individual different studies that showed the effects in the ventral stratum, value-based systems. So this is a qualitatively different system than this attentional orienting system. Okay. So in the last 5 minutes or so, right? Maybe 4 minutes. So far, before we go to the last part, I've shown you something I hope about what placebo effects are. They're modulation of affective and/or nociceptive activity that result from changes in conceptual processing systems, lateral prefrontal cortex and conscious expectations, and also value learning systems in the ventral stratum and related circuitry in amygdala. And what placebo effects are not really is self-deception, distraction, or a pure judgment and decision-making effect. Not to say you couldn't have those effects, right? But what we're observing here is not that. So really I've talked about two potential endogenous regulatory systems. This frontoparietal system here in purple, which relates to attention and sensory motor expectation, and probably plays a supporting role in developing placebo analgesia by maintaining information about the current context, the environment that you're in, and what the cues are. And then this medial orbitofrontal subcortical ventral striatal PAG valuation system that controls essentially the value assigned to a stimulus, like a painful heat or something else, and learning about that value. So a summary, a working model, is that there are these multiple feedback loops at different levels of the neuraxis. And these valuation changes here, and that's the nucleus accumbens here, project down to these systems, influence both the central and potentially the spinal effects of pain in some cases. And the VMPSC is going to be really important in modulating those processes. So it's really a model where there's multiple control systems at multiple levels of the neuraxis. And now, in the last couple of minutes, I'll just make this point that now, if we start from the brain and we say, well, what is the ventromedial prefrontal cortex and the ventral striatum? What are they involved in? We find that they're actually involved in a number of different normal and pathological states. And they include autonomic and endocrine regulation. They include threat and the regulation of threat. These are all, I'll just breeze through these findings, but they're all in this paper here. Basically, we're seeing the same sort of ventromedial PFC systems in each of these cases that modulate how you feel in terms of anxiety, in terms of subjective stress, and also how your heart rate responds, for example, to a stressor. Monetary valuation, and interestingly enough, memory and self-projection, and they're also implicated in a number of mood and anxiety disorders. So this is fear extinction recall and PTSD. This is a meta-analysis of PTSD showing hypoactivation in this area in PTSD, and this is some sort of famous older findings by Wayne Drevitz for depression, right? So decreases in depression. And so what we think is happening now, if you put these pieces together, is what I'll tell you actually right now. But to help us, before we give you the final punchline, we can look across many different tasks. And one of the things that we've done in my lab is put together this database. Each of these little dots is a published coordinate from a study. There are 5,800 studies now, and you can actually search them online, and you can search them in relation to the actual full text of the article and what the papers are talking about. And so we're using this to do meta-analytic summaries of consistent results across many different kinds of studies. And this can actually give us a new picture of what the VMPSC is doing, not just in pain, but in these other kinds of affective conditions as well. And so these are 8 maps from about 1,100 different studies that are published. And what it shows, in this case, is common ventromedial PFC activity when you're doing nothing, actually just resting in the scanner, thinking whatever thoughts come to your mind. It's high. Memory retrieval, especially autobiographical memory, thinking about yourself, how concepts relate to you, mentalizing about other people, all kinds of emotion generation, all kinds of reward and valuation tasks. How good is this? How much do I want this now? Autonomic regulation. And pain is actually special because it doesn't actually respond. It does show up here, but it doesn't actually respond to the VMPFC. Doesn't respond to the input itself, but it responds to contextual modifications that shape pain. And when we look at what these areas are doing across the two, there really are a couple of different broad factors. One is this memory, loading up context in your explicit memory, thinking about what happened to you now and what does this mean for you. And the second one is this group of emotion and reward and autonomic changes, essentially, peripheral changes. And the ventromedial PFC is the intersection between those two groups of things. So we think that it's important for essentially using specific experiences to construct expectations, not just based on what you've experienced a million times, but based on something that you might have experienced only once, or something that you just believe, or something that somebody told you. Right? So this is a critical sort of entree for conceptual information into the system that creates the learned placebo response. And not surprisingly, these systems have shown up in a lot of different contexts. The anatomist Joel Price called them systems for survival. He also called it apparently the why care system. Right? And so the idea is that this ventromedial and orbitofrontal cortex network sits at the top level of a hierarchy that goes through the subcortex and down to these brainstem systems like the PAG and the hypothalamus that are important for regulating the body, the autonomic and the endocrine systems. But they're not just output systems, they're also important in a number of other ways. So the PAG itself isn't just an autonomic output. It's really important for generating all kinds of different emotional, affective responses across different domains. And so if you look at the PAG here, it's this sort of blow up. It has these longitudinal columns of cells, and if you stimulate different columns of cells in, for example, a cat, you get different patterns of activity, and they're all different patterns of responses to threat, and they're all associated with analgesia. So these are sort of hyperactive, fight, flight, and then this is this hypoactive, give up, learned helplessness kind of state. So they're all different kinds of responses to threat. And there's a learning component to them too, right? So the idea that we have now is that over time, the activity, the responses in this system, and the responses to the pain itself is shaped over time by this conceptual information. And so the belief itself in a treatment can, over time, modify what you learn about how effective that treatment is, right? And that looks something like this. There's these systems here for encoding essentially the primary aversive value of pain, which involves the PAG and other places. There's this associative learning system, which is primarily subcortical, involves the thalamus and the amygdala and the PAG and other areas as well, which encodes these relationships. You get pain now, that's bad. This cue means pain, that's bad. And then there are these systems for meaning construction that get information from the hippocampus for long-term memory. They also get feed-forward projection from this learned value system and from other systems that represent social information and other kinds of information. And it puts the pieces together. And then it has descending control over these other systems. So it can shape both the experience and, over time, the learning. So looking forward, I think we now believe that placebo effects are active neurobiological processes related to meaning and learning systems, and that can help us understand other systems as well. And there are placebo effects in many other systems that I won't go over, but think there are then relationships with other kinds of meaning-related processes, like the voluntary regulation of emotion that plays such an important role, I think, in therapeutic, psychotherapeutic processes. Other kinds of variables that also depend on the ventral medial prefrontal cortex, like the perceived control and self-efficacy, and other kinds of things like persuasion and valuation effects, as well as a number of different kinds of disorders. Parkinson's disease is another one that placebo effects are actually quite prominent in, and involves this ventral striatal dopaminergic value-related circuitry, as well as addiction and depression. And just to give you a sort of final idea, about depression, this is how it could apply. And these connections still need to be formed. So there's actually very little evidence out there. What we do know is that there are high placebo response rates in meta-analyses of antidepressant trials. And placebo effects have been looked at in two different ways. One is to look at placebo treatment versus waitlist controls. And this has been done primarily by Irving Kirsch in a really very controversial set of studies, and recently a very controversial 60 Minutes interview. But his analyses show the picture looks something like this. Across different medications, people get better on their own. That's natural history. That's about 2.5 points out of the total 10-point improvement. The active drug effects are about another 2.5 points, and the placebo effects in his analyses are 5 points out of the 10. Another sort of very clever way of assessing this is and this has been done by this group, Brett Rutherford and Stephen Roos at Columbia, who compare the outcome when people are getting the same medication, but they're in a comparator trial where they know they're going to be getting one of two effective medications, or they're in a standard double-blind trial where they know that there's a 50% chance of getting an effective medication. So they look at only patients that got the same medication from those two groups and compare them. And what they find is that being in a comparator trial is beneficial. There's a 60% versus a 46% response rate in one analysis, and then it improves the odds ratio is about 1.53. So there's a highly significant benefit, right, to just knowing that you're going to get something that's going to help you. And I think the only fMRI, or this is a PET study actually, that I know of, this is by Helen Mayberg. She's asking here, what happens when people get have a response across time to actual antidepressant, fluoxetine, that's in red, and placebo, and both. And so what happens is increases in the lateral prefrontal cortex and the posterior cingulate, so some of the same areas that were implicated in our analgesia studies, really, and decreases in the subgenual cingulate in both conditions, as well as the insula. And so this suggests that really, at a broad level, this common circuitry is likely involved because, again, there are changes in essentially our assessment of meaning in both cases. And those relationships need to be explored. So just to summarize, this work that I've shown you is beginning to show, at a brain systems level of analysis, how and why concepts matter. And our philosophical, our spiritual, our healing traditions are rich with ideas about how to think about our experiences. Like this one. Notions of heat and cold, of pain and pleasure are born of the contact of the senses with their objects. They have a beginning and an end. They're impermanent in their nature. Bear them patiently. And that's a way of thinking about pain and suffering. And so what we'd like to know is, and what we're beginning to understand, is why these ideas might have concrete neurophysiological benefits. And that is the end. I'm going to leave you with this quote by the late Carl Sagan.
No longer at the mercy of the reptile brain. We can change ourselves to think the possibilities.
This is no longer at the mercy of the reptile brain. We can change ourselves. Think of the possibilities. There you go. And I'd like to thank you all for your attention.
We have time for questions for those of you who want to stay.
Okay.
This might relate to the perceived control reference because I don't know that reference. But I'm wondering sort of two things. One is, has there been a study where you ask somebody to predict how much pain they think they're going to have, get them to verbalize that, whether that's on the basis of processing previously or just who knows, but they then say it, and then everybody gets the same stimulation, and then you look not just at self-report but at the brain stuff? That's my first question.
Okay. Yeah. So it's people have several. We and other people, like Zubieta's group, also have asked people, how much do you expect relief? Right. And this has actually been done for a long time. Zubieta showed correlations between how much relief you expect and opioid-related increases in the nucleus accumbens and several other areas. So that's one. And we've actually shown correlations between how much relief you expect and activity in this dorsal rostral cingulate cortex that's negative. The more you expect, or the less you expect relief, the less you think it's going to work, and the more activity you show, and the lower the placebo analgesic effect is. So people have started to do that, but those are the closest ones that relate to the brain itself. But many people have done that using pain reports as the outcome measure.
Okay. And then my second question is maybe a little bit more broad. I study fear and anxiety, but the processing seems similar to me. So do you know of studies in that area, like maybe a name that I should look for, kind of like this, but instead of in pain, with like fear response, might relate to that threat detection thing you were saying?
Oh, right. Okay. So it's sort of a modulation of brain correlates of fear or anxiety.
Mm-hmm.
Yeah. So there are a number of possibilities. Some interesting things. Some of the things you might be interested in are using the amygdala as an outcome primarily. That's been the main target, I guess. And there's probably a lot of work that relates to that. And some of the work is on this instructed regulation, voluntary regulation or reappraisal of fear, downregulating the amygdala. So that would be, Kevin Oxner is one of the people who pioneered that. But Mauricio Delgado and Liz Phelps have done this in a fear conditioning setting in some very interesting ways. And they've shown that a kind of, conceptual reappraisal, you could call it that, or relaxation or something, influences both amygdala activity and influences skin conductance responses in this fear conditioning context. So that's another entree to the study of fear conditioning as a model for fear and anxiety. For some ideas.
You mentioned that placebo responders have more mu opiates and dopamine in the ventral striatum, which seems connected to me about why Parkinson's disease placebo, you mentioned that it works in Parkinson's or it's highly related. My question is, if you can block placebo using naltrexone, can you encourage placebo using some drug like Wellbutrin or something that raises dopamine?
Right, so that's a great question, and I don't know of anybody who's tried to do it with dopamine, pharmacology, dopamine agonists or antagonists. But we'd like to do that. But one thing that has been shown to be effective is proguanil, which is a cholecystokinin antagonist, right? CCK, and which is very interesting because CCK inhibits opioids in the PAG, and apparently blocking CCK can help potentiate the opioid analgesic response, that potentiates the placebo response. So that was done by Benedetti et al. In 1995, actually, but it hasn't been replicated since then, so it's ripe for follow-up.
Has it been replicated and not found to be the same, or just not?
No, I don't know if any other studies have published on it. Right. So